Advanced care planning is truly a passion. I am a strong believer that we need to remember that we as a patient are in control of our healthcare and that we have to do informed consent. And that is education is a key part of a nursing role, is making sure the patients understand why we can do different things and what would benefit them, and but really, what aligns with their values and beliefs. And so that's really what advanced care planning talks about. How do we align and move forward with that? So we are going to go and talk about what is advanced care planning. Advanced care planning is a time to reflect on your personal values and beliefs, whether they be cultural, spiritual, or just maybe some different times when you have seen other family member or friends, or maybe something in the news media of what medical situations have occurred and different outcomes and options. And it's a time for you to reflect on how that looks for you as an individual and as a person. It's an opportunity to discuss with your family, your friends, and your healthcare providers, what are your wishes for medical treatment in the event that we don't know what is going to proceed in our health and our life. It's a time to appoint who you want to be making decisions and speak on your behalf when you cannot speak on your behalf. And it's also a time where we document. Documenting in a legal format of an advance directive secures anything that you've thought or said to uphold your wishes in healthcare per the law. So, who should participate in advanced care planning? Anyone at any age. We can begin advanced care planning at the age of 18. It's encouraged and should be. Any individual can complete an advance directive. Now, we do have to recognize that they do have to have decisional capacity, meaning that they're alert, they're oriented to who they are, where they're at, and understanding what they're completing this document for and why. It cannot be, the power of attorney for healthcare cannot be completed on another person's behalf. And we should include our family and friends in this conversation of advanced care planning. We want them to know what our thoughts are, what our wishes are. So if they have to help interject and support us, they will know what we would want in certain situations and what we wouldn't want. They would know how to pause in that moment and say, wait, I remember when we talked about this. It's just an ongoing conversation. And definitely your healthcare providers. You really want to know with your healthcare providers, what is your current state of health? What might be your understanding of that disease that you might have and how it progresses and how different treatment options and this progression of disease will impact your life and your outcomes. So we want to know, why do we engage in advanced care planning? Well, we engage in advanced care planning because our health changes. As we age, our health changes. We've all seen it in family and friends or in the media, how we age and our health changes. We don't know what's going to come ahead. And so we know we want to be aware and be prepared. We also know that medical crises can occur undetected. Many times, you hear someone having a stroke with no symptoms prior to that, or a cardiac arrest, or injuries can strike unexpectedly, a work injury, or it can be a car accident. And we engage because we allow reflection and sharing of important life outcomes. We all kind of have a feeling of what we would want our life to look like, but this is an opportunity to really get it documented and get that discussion beginning so someone has a better understanding. When do we begin in this advanced care planning discussion? We begin in that discussion right now. And you're interested in it. That's why you're here. So we begin because whether you're in a healthy state or you have a new diagnosis, it's important to start taking that strain away of when you get into that crisis moment. You're now admitted to the hospital, or wow, this disease progressed unexpectedly. The treatment wasn't working. And we want to begin these discussions so we're in this calm environment and we can just kind of talk freely and think about different situations versus in that moment of panic and thinking, I have to make a decision right now. We want you to begin that decision making early, do you have time to process it, to kind of think it through, talk with others? Because your advanced care planning decisions can change at any time. And that's important and that's good because our life changes, our health changes, medicine changes. We've seen a lot of journey and advancement in healthcare in the last 10, 20, 30 years, and it will continue to progress even more rapidly. So your wishes and your preferences can change at any time. Another time to begin is when you do get a new diagnosis of a disease. When we have disease, it's life-sustaining. Some diseases can be very life-affecting, your daily outcomes and your daily activities, and some can just kind of be more stagnant in the background. Oh, I have a little high cholesterol. I need to kind of change what I eat, maybe take a medication. But then you have to remember with high cholesterol, that could affect other components of your cardiac system. And it can then, once one organ system is affected, it kind of affects the next organ system, and then you have what we call multi-organ components failure symptoms. And when disease is progressing, when we see that things are changing in our lives, maybe we can't do what we did last month, 3 months ago, 6 months ago, last year, or when we see, we were admitted to the hospital, and then now, wow, I'm readmitted, or I'm having, more frequent readmissions or different things happening. Every time there's a new occurrence in your health and a change that alerts you to go to the doctor or hospital or facility of care, then we need to kind of talk about what's going on. And like I said earlier, it's a constant changing discussion. What we are going to talk about now with your health might be different in 6 months. It might be different in 3 months or 3 years. So what does advanced care planning do? It allows you to identify different medical decisions to be made in an event when the individual is unable to make one for themselves at any time of their life. Advanced care planning emphasizes the purpose and function of an advance directive, and we'll get to those advance directives in a little bit. Two of the advance directives that we use most frequently is the power of attorney for healthcare and the POAHC, the provider order for licensing and treatment. And I'll go into the details of those in a little bit. ACP, advanced care planning, also eases the discussion of a disease process and those outcomes for medical care with your family, your loved one, and your healthcare providers. And it aligns the personal values and beliefs with the medical plan of care for outcomes. We, most importantly in the healthcare world, want to respect and honor your wishes, your values, your beliefs, your cultural preferences that impact how we care for you, what you want, and how they will impact your life. So the different types of advance directives. Advance directives as a term is an umbrella word for any legal written document, which allows an individual to appoint an agent as their medical decision maker, and it also allows an individual to make selections on when the authority of decision making begins and different feelings or preferences of care in different medical situations, more complementary to the end of life. How you would want, if you were in a terminal irreversible condition, how you would want to have your medical care treatment to look. So the power of attorney for healthcare, and I put our little abbreviations, POAHC, is the advance directive naming the agent. Who is that person? You might have heard surrogate or proxy, and we're kind of collaborating and unifying the word. So agent and POA specifically refers to you have a document on file and you've named that person to be your agent. And they are then able to make decisions in the event that you cannot make them yourself. You also name successors because sometimes we can't get a hold of that agent. Maybe they've passed away. Maybe they're off in the area where they don't have cellular access, or they're at work and they can't take phone calls. So we always want to have at least one successor or two as a backup. Hopefully in most situations we have time to get a hold of the agent, but there are sometimes where there's urgent medical needs, and as healthcare providers we need to have an answer quickly. The Jehovah's Witness Advanced Healthcare Directive is another form of a power of attorney for healthcare that we honor and respect in our state and within our healthcare system. And that again names the agent and successors to be making decisions on their behalf. And it also specifies that religion preferences for different medical interventions, of what they will accept and what they don't support. Again, that's where we really need to have that information in an advance directive, because that's your protection and our protection to follow your wishes. Then there's the 5 wishes. That's another document form that tells who is your partner in healthcare. That has a lot more detailed descriptions about how you want your environment to look at end of life and how you want your care to look, really more in a personal, intimate manner, about bathing and eating. It just aligns it out much more detailed. Those are the 3 documents that designate who is your power of attorney for healthcare. Those 3 forms can be completed by anyone with that decisional capacity at any time. You do not need an attorney to have that form completed, and you do not need it notarized. That is for this state of Illinois. And at the end, I'll give you the resources of how to get those documents and how to help get those documents completed and supported. You do have to remember, in completing advance directives, there's stipulations from the law of Illinois regarding who can witness these. Again, it's just in protection to make sure that this is valid, that the patients are really filling it out for themselves. Then the other advance directive that we utilize is the POAHC, the Provider Order for Life-Sustaining Treatment. Many of you might have heard it in the past as the DNR, do not resuscitate, do not intubate. The state has a committee that works on this, and they've just revamped the form where you can complete it. You don't need to have a witness. It's an order, so it does need to be signed by the patient, or it can be signed by their legal subject decision maker if that person is not available and capable of making their own decision. And it's signed by the doctor because it is an order. That POAHC, as we're going to look at, talks about CPR, resuscitation. And you have the option to say, yes, I want CPR when my heart stops and I'm not breathing, or no, I do not want any medical interventions. I accept that as my time of death. I don't want to have chest compressions, compression of the ribs. I don't want to have intubation, being put on that respirator, breathing machine, ventilator. You have that option. Without this document, the state mandates that we give all care to every person. So paramedics, the Good Samaritan at the grocery store, in the healthcare setting, we have to, by law, do everything for a patient to revive, sustain life, unless we have this paper that says, stop, do not do something. It's an order, it's documented, it's signed by the patient with acknowledgement, or the legal subject decision maker and the provider. The provider signs it because it's an order not to do something. And it then is a discussion with the provider saying, yes, this makes sense for this patient not to have aggressive interventions. They're at advanced disease, they're at end of life, that CPR wouldn't benefit a patient and bring them with better outcomes. It's really hard. We don't know how anyone's going to respond to CPR. We've had some amazing miracles that someone has had a cardiac arrest and you can revive their heart to beat again, their breathing, and you can get it on their own, or sometimes they're still supported by machines. That's why advanced care planning is so important, for you to think about it and discuss, if I had to have this, would I want that outcome? Do I want to take the risk of knowing or not knowing? Or do I say, no, do not resuscitate. I have faith. This is, I have a strong spiritual connection. When this is my time, it's my time. I don't want to put any more burden onto the health that I already have. And because we know that without oxygen to the brain, we do have vital organ damage. We need to get that blood circulating. We need to get the oxygen. So all patients can have that opportunity to get that vital functioning back, but without oxygen and the blood circulating, we have damage to those major organs. So on the POAHC, you have that opportunity to say what you want. Again, if someone wants CPR, we all have That's a valid law and expectation. So we really don't need to complete that form. But if someone requests do not resuscitate, they talk to the doctor, that's in section A. Section B allows you to say, as I have life, I have a heartbeat and I'm breathing, but a condition might be changing. I'm presented to the healthcare facility or I'm at the health facility and maybe I'm having difficulty breathing. You have that option to be in control of your healthcare to say, do I want full aggressive treatment, everything to sustain life, put me on a ventilator, the breathing machine, intubate, or no, I never want to be urgently intubated. I want to have more control over that, or I want my agent to have more control over that. But I do want to come to the hospital. I want to have operations. I want to be cared for. I want antibiotics. I want the condition of what I'm there for to be taken care of, to be treated, to hopefully get that point of recovery. There's the other section of comfort. That is truly if someone has had discussions with a doctor that you are at an end stage, terminal, that the doctors really feel 6 to 12 months is the expansion of what this disease is going to sustain your life to. And then that's really a discussion of having palliative team supporting symptoms and having hospice care. And hospice care and comfort care does not mean that we're not treating the patient. It's just saying that we know end of life is going to occur sooner than later. So we want to really take this opportunity to really detail that medical care to sustain that life with the best that it can be, with managing those symptoms, keeping them in and out, keeping them away from being in and out of the hospital, reducing the strain, really thinking about how you want that end of life to be when you have that opportunity to make those decisions. And then section D talks about medically administered nutrition. That's very optional. Some people are very strongly confirmed, I do not want to have feeding tubes. Some people say, oh, I'd want them for maybe a trial period, or others that are going to say, no, yeah, go for it, no matter what. So it's an opportunity for you just to kind of give it as a guide. You cannot select anything on that component too. It really is a preference of that individual. But section A, if you select CPR, then you have to select full. It's noted on that form. So if you want CPR, you want all measures to sustain and revive. So that means that as you are alive, you want all measures to sustain and survive. But if you say no DNR, then you have the option to do that restrictive care in the middle. Now, just as a reminder, if you have a DNR and you say selected that you wouldn't want intubation, there's exceptions to that as if you needed to have surgery. Let's say that you have a DNR with selective and now you have a broken bone. You need to have surgery to fix your broken femur. That surgery involves anesthesia, which involves intubation for protection and to get in the safety of the procedure and to give you the best pain management. That's a different form of intubation. That's for the procedure. This form is talking about intubation, ventilation for life sustainment. So it's always important to know that there's a difference there. Or if you do, again, like we talked about, these documents can change. Maybe someone has do not resuscitate selective, they come into the hospital and they're now having respiratory distress, and the doctor recommends that you're having pneumonia, you're having sepsis. But the event of putting you on a ventilator could help support a better recovery, a better opportunity to recover. You can change your mind to do something for yourself and be intubated, or your agent can, if it's in the best interest for a positive outcome that would align with your values and beliefs. Again, these forms can be changed at any time, and they can be completed by yourself or your agent on your behalf, but it's always discussions with the doctor. We do like to keep it on a bright piece of paper. We always do pink, so if it's in a pile, you can see it quickly. We want it visible and available for paramedics and other emergency technicians. Someone said my voice is scratchy. Okay, hopefully you can hear me. Okay, advanced care planning information, additional advanced care planning information. Again, cannot express enough that the patient must demonstrate that decisional capacity to complete the document for power of attorney for health care. The post can be completed by their agent for the law. Documents do not expire. They are, we've had documents come across us from the 1980s, the 1990s, or just current. They're also honored across state lines. It is best if you move from state to state to complete a document within the state of your residence, as each state has a little bit differences of their law. Again, we have a very open, flexible law where you don't have to have it notarized with an attorney, but some states do require that. And just in a way to protect yourself, it's best to complete it. We even recommend for patients who have two residents in two different states, they spend half the time here, half the time somewhere else, to have two different documents in two different states. Again, it's a way to protect you. You complete these documents to be your voice. So we want to make sure that they're valid and you're protected. They can be revoked at any time. At any moment, the patient can say, I revoke this document. I don't want this person to be my decision maker, or I don't want those selections anymore. So then we just have to note that in the chart, and then we can, update your chart with that. It's always encouraged to complete a new document, so that way there's no concern or there's no questioning of which document is the most valid. Sometimes it's possible, sometimes it's not. On the power of attorney for healthcare, once you complete the form, it says that, who's the person, their address, and their phone number. So what can be edited on the form is a phone number, an address, or last name. Someone got married, someone got divorced. But what you cannot edit on that form are the selections you made, or you can't change the order. So if you had Bob as your agent and Sue as your successor, you can't sit there and arrow around. Technically, in the law, that's not a valid document. We have to follow, because we don't have that evidence that you as a patient really, altered that, and that was truly your wishes that someone just did for you. So if you need to complete a new document, it's the easy thing to do. Next, we had a chat. Ashley, do you want to get to that chat? Talk about it now?
Yeah, no, I was just, I was actually chatting back and forth with Maureen here. She said when my siblings and I were caring for my mom, we each carried a copy of her DNR with us in case we needed it. And I actually did the same when I was caring for my dad. My brother and I did the same thing. We just carried that copy with us all the time in case we needed to produce it. So I think that's a great idea.
Yes, and that is, I'm so glad that was brought up, because in the healthcare facility, we have to see that document. And COVID was amazing because a lot of people were carrying those forms of their loved ones, and you can have it electronically. We have to have it visible to us. That's our source of truth as that care provider, to know who we're talking to legally. And then it's easy. We have many patients just email it to us, because in NM we have a very secure email system, and then we print it and then get it scanned into the chart, and boom, it's right there for the next caregiver, the next shift, and there's no questions asked. And once you have it filed in your chart, it's good to go. Great point. So this is kind of with that, what do we do if we don't have an advance directive on file? We have to then follow the Illinois Surrogate Act. There's always someone appointed to be your decision maker. So in the Illinois Surrogate Act, it files a next of kin, and there's a priority order. So again, it's why it's so important. The healthcare power of attorney could be the same people, right? The listing of what the Illinois Surrogate Act is. However, the power of attorney for healthcare allows you to select authorization of when decision making can happen. And once you have a power of attorney for healthcare document completed, that individual and successor, they have broader authority in decision making. They can be involved in that decision making at any level of care. We don't have to wait till it's determined that there's a terminal, incurable, irreversible, or permanent unconsciousness. So it allows that person to intervene on your behalf sooner and have that voice and say. So it's so important. But yes, the law tells us who is going to be in charge. And at any time, the appointed individual to be making those decisions, whether it be a power of attorney for healthcare document or whether it be the surrogate act. Anyone can sit there and say, I don't want to be that decision maker. I can't do this. You know, the moment came, or maybe they became an estranged relationship. They can revoke and rescind their appointment. Then it follows the next person in line. So if it's a healthcare power of attorney document, it follows the next person on the line of successor or the next person in line of the Priority Act. And we do need to see those documents. Again, like I said, we have to physically see a document. So many times people are like, oh yeah, this is my power of attorney for healthcare per the law. And we follow the law because it's a protection of the patient, it's protection of the staff. We have to see that document. We've had times where patients have presented and they're not decisional, and individual X comes up and says, I'm the power of attorney for healthcare, and they're starting making all these decisions. And then we identify later that either there was a document on file and they're not listed as the power of attorney for healthcare, or, you know, per the Illinois Act, they're not in the appropriate order to be making those decisions. So it's so important to have that on file. And this is why we want to get on educate, because it's important for you to know why we have these and who is that decision maker and why we go through those different phases, and ask every time you come, do you have an advance directive and how do we get it on file? And we can get that document on file when you come. You just scan it into your chart and then it's there. And then you'll be able to see it on your My Chart also. So here are those resources. If you go to Northwestern Medicine online, there you search Advance Directives, it'll take you to different links. You can print out the documents and get them completed. You can upload them onto your My Chart, take them into your primary doctor's office. They can scan them in. You can take it to the hospital. They can get it scanned in. It is a requirement from the Centers of Medicare and Medicaid that we ask every patient, every admission, do you have an advance directive? Can we help you complete it? Can we get it on file? Again, after this discussion, you've identified the reason why, because without it, we have to use a different order. And it then allows that decision maker to have broader authority to decision making. We never know our health condition, how we're going to present. And even for an individual who comes in for a planned surgery, maybe there's a complication and then they, you know, there's a change and they decline, and then who's that decision maker? So it's so important to begin that process now, have those discussions, complete those documents, get it on file. There's also at the Illinois.gov, you can pull out the Power of Attorney for Healthcare statutory form from that Illinois website. There is the post form, and then the home post has just wonderful information. So if you sit there and say, I just want more information, I got to talk about it with my family. We encourage those discussions with your family, because what's so important is they understand what your thoughts are and how that looks in different scenarios. And then the National Institute on Aging has a really nice website that just goes a lot, discussions about advanced care planning, why we do it, the value of it, the importance. Our health changes all the time, and it's so important to get those discussions going, understanding where your disease is. We come and say, we can do this, and we can, there's lots of treatments and options of care, but we always have to pause and say, as a person, as a patient, and an individual, what does that do for me? What will that benefit me? What's my outcome? And stop and say, is that what I want? Is that going to give me the best outcome? There's always options. You can always try different medical treatments and then decide and say, that wasn't working for me. Let's stop that. So what's so important is that you're in charge of your health and your plan of care. Ask a lot of questions. You're your own advocate, your agent or successor, your surrogate, they're your advocate. We speak healthcare and it's such a complex language. And then with each specialty, there's a different language. And we want to make sure that you understand what benefits you, what's happening, that you know your disease, the options of care, and what those outcomes, and align those to your values. We are here to honor and respect you and to care for you the way you want to be cared for. Any other questions?
I actually had a question for you. Could you go through just the first couple of people in the line of succession under the Illinois Surrogate Act? So if you don't have a POA, who is acting as your person legally?
Great question. So the Illinois Surrogate Act starts with guardian of person. So if a patient has ever been deemed incapable and not making their own decisions, then you go through this court system to get guardianship. That most of the time, that's always done prior to ever being admitted into the hospital. They have a extreme neurological cognitive deficit, and they've identified that, and they've gotten guardianship a long time ago. There are sometimes that there's been, a severe medical change, and there's been guardianship. Guardianship occurs when there's like no one in that situation where we can't identify someone. So the guardian of person, and then you have legal spouse. So that is who you are legally, married to. So if people are going through a divorce, it's important to get that changed because during that process, until it's official through the court system, they're technically your decision maker. And so you have the legal spouse, then you have adult children, and then you have parents, living parents, and then you have siblings. And as you hear, I'm emphasizing the plural of those groups. Once you have a group of people, per the law, they're all supposed to have equal say. We identify one person in that group. So let's say you have 5 adult children or 2 adult children. We have to identify who's going to be the spokesperson. In the healthcare world, we just need one person to be contacting, giving the story to, asking the question, getting the answer, and then it's that spokesperson's responsibility to contact the other members of that designated group, have that discussion. So sometimes that goes well, and other times, you get more people involved. There's differences of opinions and values, and so the conversation can be more strained and more complex. So that's how it goes when you have the group: children, parents, siblings. And then you have a close friend, a close friend. And so we've had times where we've had patients come to say, I have no one, I don't talk to my family, or they all have passed away. And so then we, kind of really talk with them to say, do you have a close friend? Do you have someone that you know and trust who could do this decision making for you? And I think what's important to realize is making medical decisions for someone, being appointed as that person, does not put you in financial responsibility. You're not responsible financially. It's just saying you value the patient, you care enough about them, you know enough about them that you want to help guide decisions in a reflection of how they would. So if they could be present in this conversation, what would they say that they would want? These decisions aren't supposed to be made on how we would want them. We have to reflect, how would the patient, what would the patient say or do?